My name is Jose Herrera. I'm the pediatric orthopedic surgeon in Arnold Hospital for Children. We have in our hospital 4 pediatric orthopedic surgeons that we do spine, hip, trauma, you name it. We train residents and fellows, so people that are going to do children's later. We do research. We have one of the biggest NICUs in the planet, if not the biggest one, a lot of deliveries, so a lot of opportunities to take care of patients. And we are in the U.S. News and World Report ranked for the 7th year in a row. So Arnold Palmer is, you know that beautiful building with the glasses? No, it's this one. So it's a tiny one with bricks. It's the old one, yeah. Hopefully eventually at some point. So fresh from the oven, we hire more people to help us. We're hiring a partner. Actually, we're interviewing in the next weeks to have a 5th partner because we're busy and we're doing a lot of good stuff. So hopefully they will continue growing. Our floor, if you have been a patient or know somebody, we finally fix them. They're like nice and pretty, they're comfy, patients like it, and we have a new machine for some of our patients for scoliosis, less radiation and what have not. So what Tricia wanted me to talk about a little bit about scoliosis. So this talk is a little bit of common stuff, some of syndromic things and things like that, and things that would apply maybe to all of you. But basically, the definition is a crooked spine. So basically, it's crooked, and when kids tell me that, I tell them that that's exactly what it means, that scoliosis is crooked. It's a lateral deviation of the spine. So anything more than 10 degrees is considered abnormal, and we need to take care of it. It's not the same as rib asymmetry. Some children, where we see them, the ribs grow more on one side than the other ones, and but you do an X-ray, they're perfectly normal. So this forward bending test that we do for some kids is not completely 100% accurate. We look at vertebral bodies, which is the spine, and they have some elements that we'll consider here. We have anterior elements, posterior elements. The spinal cord will be this cable here that we have depicted as. And when we usually do surgeries or procedures, we usually go from the back, but we have to take into account the front part, the development, and what happens with growing in the spine. Why does it happen? We're not sure. Who caused it, what caused it, and what came, who did it, we are not sure. There's some genetic components that we look at the parents, and sometimes the kid has it. And if mom had that habit, it's about 80 times more chance of having scoliosis. Genetics takes some of that into account. Melatonin, it's a bunch of things that are, but basically at the end of the day, we are really not sure why it happens. Sometimes people say it's excessive blood flow, the spine grows more in the front than in the back. And in patients with scizencephaly and what have not, it's more muscle imbalances as well, plus the growth, accelerated growth. So sometimes some of these curves behave more like idiopathic, some of them behave more like neuromuscular, so we have to keep an eye on that and make a decision what to do if we need to do something. So one of the biggest questions they always ask me is, are there any types of spinal deformity? I mean, it's just scoliosis, or is there more than that? And the answer is absolutely yes, and we classify them by type, location, age. The type usually are either congenital, and we'll show some examples. Neuromuscular, which are the ones that pertain to our population here today. Myopathic, muscular dystrophies. This is neurofibromatosis, so these are very severe, very accentuated curves. Idiopathic is one of the ones that we treat the most. The location, is it at the neck, in the spine, in the middle of the spine where the ribs are, at the lumbar spine, all of them, none of them, and what have not. And then by age, we have from the little baby to the tall, big guy, and it all depends on, again, the age and the time of diagnosis. We do some radiographs, and for the most part, when we do their radiographs is sitting, so we can see how the pelvis is level, how the shoulders are level, what is decompensated, what do we need to address when we take care of our patients. For other patients, it's standing, again, because we need to see the pelvis level when they stand, when they walk, and what have not. But important stuff is the position in the wheelchair and what have not. We'll go over that in a second. So how do we measure it? Because, I mean, you may have seen your surgeon or doctor take a look at it. And basically what we do is we have the x-ray and we try to measure the worst curve possible. So some people will try to measure here, but this is the worst one here, this is the worst one here, and then from here to down here, then we measure a different curve. And those are the ones that give us parameters. And when they go into follow-ups and they see each other, let's say every 6 months or every year, depending on the age and what have not, the doctor is looking at the one x-ray before from the previous visit and the one that they just have done that day. And if it's more than 7 to 10 degrees, it's a significant change. If it's 2 or 3 degrees, don't get too excited about it. Don't get too upset about it, because there's how many people here in the room, and let's say usually in the office, like 3 or 4 people. If 3 or 4 people measure, somebody can measure 20, somebody measure 21, somebody 19, 22, it's all the same. As long as it's not like 20 and next visit is 30 and next visit is 40, that's when we get really concerned, okay? And that's very important because we get hung up on the numbers. But try to remember the numbers just for the sake of it, because sometimes the doctor is not completely sure what the number was before or can't find his notes. Or if it's you have moved and you're in a different place and you don't have the old records, yeah, he always told me 30 degrees or 27, whatever the number that is, okay? Physical exam is part of the stuff that we need to do. It's interesting, not only x-ray, we need to look at the patient, we need to look at everything else around them, and obviously these guys are very involved in several areas. We look at any type of pain, any bladder issues, or if they ambulate or do not ambulate, even the feet, if they're tight, if their muscle contractures, their necks, everything is important. And we look at their back posture. Are they sitting forward? Are they sitting backwards? Sides? All those things are important to try to come up with a plan, either to put them in a brace for a while, or to surgery, or just accommodate them in a wheelchair for them to be comfortable. We look at the exam, and some of them have hairy patches, especially patients with spina bifida. What curves will progress, and these are for more idiopathic patients, but I will say for anything, I tell all my patients, anything more than 50 degrees is going to be surgical. If anything is more than 30 at age 10 or less, usually it's going to end up being surgical as well. We can try to prolong, brace, and what have not, to try to get to maturity, then to do only one procedure rather than do a couple. And sometimes they need a couple of surgeries, depending again on the age and their maturity and the severity of the curves. Idiopathics are the most common kinds, so the teenager girls that are cheerleaders and what have not. How do we treat them? There's 3 ways that we treat scoliosis. We either observe and keep an eye on them, we brace them, which is the orthosis, or we operate. And we'll go over that. Physical therapy and what have not, stretching and dangling from the ceiling and all that stuff does not work. It's basically, that helps in the sense of keeping them flexible, keeping their spines in shape, their muscle tones, their lower extremities, the sitting ability and all that stuff is important. So not only I'm looking at the spine, I'm looking if he can sit on the wheelchair, or she can sit on the wheelchair, is it slipping forward or backwards? Do we need to lengthen tendons in the legs to be able to sit down, or try to be simpler, right? Orthosis is usually used in this patient population more for preserving and posturing, sitting them up straighter, keeping them proper so they can actually use both hands. Some of these guys, if you don't brace them and they're listing, they try to use one hand, trying to prop with one hand, and we're trying to do OT and things like that, and then you only have one hand. By bracing them, sometimes we can sit them up properly, posture them better, so now they can be a little more active. Or maybe put them on a standing, if we can do a standing program, depending again on the severity and the condition. And then operation, like I said, 45 to 50 degrees. I like the 50 number. Everybody remembers 50. That sounds like half. If you get over 50, you need a procedure, because the natural history is that it will get worse and worse with time. These are some of the braces that we use. This one is almost never used now. Kids don't like it. And our patients also, they get pressure sores. They cannot complain about it, so we usually do more of these. And sometimes we use the softer softer braces just to prop them up and sit them up properly. There's some bending braces at night. Once in a while I will use it, but more on teenagers. The purpose of the curve of the brace is usually to prevent it from progressing. Usually does not help improve. And for patients with neuromuscular conditions, sometimes I use it again for sitting or to maintain the curves flexible so the time comes for surgery, the curves are easier to be managed by the surgeon. So those bracing out in the natural history, they're absolutely not, okay? Again, curves more than 30 in female patients, 83% ended up in surgeries if they're immature. The surgeries have evolved. Before it used to be a cast only. They will stretch you, put you in a cast, and fuse you, and that was it. Now this guy came and started instrumenting in the 60s. He was almost thrown out of the society because he started using rods in spines, and they thought it was barbaric. Nowadays, if you see what we use, and I'll show you in a second, how much we evolved. This is more the type of construct that people are using, this one and screws, and I'll show you an example. Basically what we do is release the spine, level it off, and with the wires we tighten them in a certain way to try to level the shoulders, level the pelvis here, and make them more comfortable. There's other rods and we'll have other techniques as well. The goals of surgery in every case is to prevent the spine from getting worse. You don't want it to go to 60, 70, 80 degrees because it will start altering function, breathing function, sitting, posture, everything. And it's very inconvenient. Some people have this thought that it's going to push on structures like kidneys and the heart. It does not do that. So some people will tell you it's pushing on the organs. That does not happen. Don't worry about that. If the patient is having other issues with, let's say, for eating or what have not, talk to the GI guy, and then they will take a look at it, but it's not from the scoliosis, okay? Before surgery, if we do surgery, we sometimes pre-donate blood, but we don't do that often now. We do more donate blood from donors and what have not. We do a lot of stuff with their blood volumes, their pressure, so minimize bleeding. Most of these surgeries are now done from the back, so basically the patient is placed on the belly, and we do the surgery from the back. Sometimes very rarely, we have to go from the front, do some releases, and then go from the back. And depending on the surgeon, the center, the experience, the severity, it's either done the same day, a week later, 3 months down the line. Again, there's a bunch of varieties that it's not worth going through it right now. We use hooks, wires, screws, you name it. There's a bunch of things that we can use to try to straighten out the spine. So these are examples of hooks. So basically they cling on to the posterior elements of the back. They're cheaper, low risk. The long history, they've been used for 50 years now, by now. But they're not as strong as a screw fixation. I'll show you a screw. So you can get a curve like this, put some wires, some screws, some hooks, and then screws at the bottom, which we call a hybrid because it has 3 elements. Or we can use screws. Basically, these go into the vertebra around the spinal cord. So you need people that know what they're doing, trying not to put the screw into the spinal canal. But the fixation is stronger. The correction is amazing. It's one of those things that it's very powerful. They're being used routinely in basically every center right now. Not many, almost every center has somebody that does them. They're better correction than the hooks. But you need to train, and you need to know what you're doing because otherwise you can hurt a lot of patients. So that's the same patient before and after, and she was doing some weird cool stuff. So sometimes the patients are limited, sometimes they're not, and most of the times they're not. So the other question we have got sometimes is what kind of spinal deformity can I correct? Can I do a 50, 60? Pretty much we can correct anything. Again, it does involve that the patient has a proper nutrition, that the family is ready for it, a good social environment, a good team, anesthesia, intensive care unit if we need it. You have no idea. It's just so many people. Oops. I'm not on call today, thank God. Okay, anyway. So, yeah. But it does happen. So one of the other scoliosis types that we were talking about is the neuromuscular one. Cerebral palsy and patients with neuromuscular conditions, they will get scoliosis. Some people with spinal meningocele, the famous spina bifida patients, spinal muscular atrophy, There's another type of neuropathic scoliosis. In the non-ambulators, what are the goals of surgery? We said before, trying not to have the curve progress. We usually make it better anyway. But in a non-ambulator, usually what we want is a straight spine that is balanced. The shoulders and the pelvis are level. And try to have the hips loose, because the sitting position, pressure sores, they cannot complain as much as we do. They cannot, for them to prop themselves or sit up in a proper way is different, so they will develop the pressure areas. And that's very important when we do neuromuscular patients, because we need to make sure that they are comfortable. And we actually published an article that we found about a third of the patients with neuromuscular scoliosis that we were fixing them, then they'd start developing hip issues because they got tight, they dislocated after the fact. So the families need to be warned, if you're going to have surgery, that this may happen in 1 out of 3 patients, and that's a lot of people. And then on the ambulators, what we want is, again, a balanced spine, level shoulders, but some of these neuromuscular patients are ambulators after all, and we need to treat them like idiopathics, try not to fuse to the pelvis so they have good mobility. It's a patient with myelomeningocele. He has about 114 degrees of curve, so basically more than an L. And they were the ones that came up with that. It's a brilliant idea. I still use them. They're very powerful. And it's cheaper for the patient, the hospital, for everybody. And you can still get good results. Again, 107-degree curve. Nowadays, I would probably consider using screw system, because it's more powerful. They're very stiff. I went from the back only, and with just wires, we were able to achieve a pretty well balanced shoulders, level pelvis, and the sitting position was preserved as well. But I'll still use the screws now, even though I know I can do it with wires. I don't know why, but yeah. And before and after. This is one of my dear patients. It was done about 10 years ago. He has a syndrome, a paralysis Merzbacher. I met 2 of them, him and his brother. He was lost to follow-up. He had about a 70, 80-degree curve. Somebody told them, you need surgery, and they got scared. And the family got worried, and they flee the hospital or the office, and they came back 2.5 years later, and I was the one there. And from 80 went to 135 degrees. So you can see the curvature here is almost like a hairpin versus this is more manageable curve. So my advice to you is, if you fall into that situation and your child, your cousin, your niece or nephew has it, and the curve is bad, somebody recommends surgery. If you don't feel comfortable with that surgeon, find somebody quickly and see, or get a second opinion. I always offer second opinions to my patients. I go find somebody else and see what they say. You'll end up coming back here anyway for me to do it, but sometimes they go to somewhere else, and that's fine, and they do okay. And that's what happens. If they disappeared all of a sudden, and I'll show you another example that I have, it's very dramatic as well, they end up with curves like this. So for this one, it's a little bit harder because we had to really put our muscles in it. And for him, his curve was still just as stiff when we tried to stretch him. We made some decisions on what to do. This is the way he was sitting, he was standing. His pelvis is completely oblique, his shoulders are oblique. So basically we need the shoulders to be level and the pelvis to be level to have him a better seating. He was not an ambulator. We did some special techniques, put some traction. This is basically distracting the spine while doing surgery. We did a stage procedure. We did some correction. It's not pretty, but we staged there, stopped. He was not paralyzed. Everything was working. We close him up and come back in 2 weeks, and we'll go again, and we'll finish the job. And that's what we did. And at the end of the day, he looked like that. And I'll show you.
But he was happy about that.
And Mama too. Obviously, his little brother came with a 70-degree curve, and I fused him at 70 degrees and not 135 degrees. So it was a quicker day. This was about 8 hours later between one thing and the other one. But again, there's still some curves, but they're balanced, and now that he can sit up nice and straight. Look at the shoulders, nice and level, his pelvis as well, no ulcers or anything like that. Usually my wounds are straight when they start, but sometimes when we correct them, they end up with a curve. So it's not that I don't know how to draw a straight line, okay? Are there any congenital anomalies? And of course, anybody born may have has a chance of having a congenital issue, right? So these guys, not this type of patient, but there's patients that will develop that, and it has other associated conditions, and some of these apply to our population. And the answer is yes, of course. So let's see, the term congenital is a little bit misleading because it means that they were born with a curve. Some of these guys are not born with a curve. They have a little defect and a normality of the vertebra. They, with growth and development, they end up developing the curve. There's two types or a combination of both. Either the spine does not segment or does not divide, right? Or has a bar on one side. Or, and these are a problem because if the spine is fused on this side but keeps growing on this side, you can imagine it will start continue growing in a crooked way, okay? The other one is failure of formation, meaning that the spine, you saw that they were like more rectangular shapes, only half of it grows or forms with birth. So we have little, see, like triangles and what have not. And those can be also a problem. Sometimes they're in combination, so the patient may have that little wedge here and then the bar here, that one that doesn't grow, so it actually grows quicker and gets worse right away. We do CT scans, MRIs, and what have not. Oh, yes, sir.
Yes, doctor, this may be kind of a dumb question, but if a child then if he's born with, let's say, the pedicles, is that then if they're shorter at birth, if that's a genetical defect, can that make a difference? I mean, does that...
Shorter pedicles may, the only thing with shorter pedicles, it may be that the spinal cord may be a little bit more tighter in the back. And that can happen with some of the achondroplasia and other syndromes that are short stature patients and what have you. They can have some of those problems. The funny thing is that the pedicle can be, when you look at it from the front, when we're doing our instrumentation, we can see them. And I'm 6'1", and my pedicles may be this tiny that you can even put a little needle through them. And maybe a 5-year-old, any 5-year-old, you see them, they're huge. You can drive a truck through it. So it has nothing to do with height, nothing to do with size. It's more like the anatomy, your anatomy, whatever it did when it did. But yeah, we look at that. But usually the pedicles are pretty predictable, the size, and usually that's not the biggest issue. The biggest issue is the width, how tight they are. So when we're trying to instrument, so we don't go into spinal cord and things like that. Okay, but that's a good question. We use CT scans and occasions like this and what have not to see how tight or tiny or thin or something if we need to do planning, especially when we do congenitals, because some of these vertebrae need to be removed, and we remove them. I'm not going to show you what we do because otherwise we're going to pass out here. But it's pretty cool. Always, when you have a congenital, always look for another problem. So if you see one that is obvious, there's another one lurking around for the most part. And besides that, we have to look at other things associated, because embryologically, when you are being cooked in the belly, right, in the oven, besides your spine, your heart and your kidneys are being formed at the same time, okay? So when I see a patient with a congenital vertebral anomaly, 60% of them may have something else. One kidney, a horseshoe kidney, no kidney, heart anomaly, and things like that. And then besides that, 40% of these patients may or may have combined this and another abnormality of the back, and that's why we're saying 40%, so you have to look into it. Okay? Oh, okay. And we have to look for all these little things and tricks and secrets, okay? Bracing does not help, but I think for the compensatory curves, it helps to keep them straight and flexible while we get to them. Sometimes they need surgery at 2 years of age, and sometimes they never need surgery, depending again on the type of curve. Again, this is one of those I was telling you about, that the patient has like a little bar here, so this is not growing, this is growing, and in addition has a little wedge here. So see how quickly they progress in a year and a half, from 40 whatever to 60 degrees. So we need to keep an eye on them. Again, don't get lost. If you see something and you don't like your surgeon, go find somebody else. But don't disappear, because this is a problem later on. And later on, they disappear anyway. Now they're 93 degrees. This is the same kid. 4, 5, and now look at that. And age, I can't remember the age right now, but it can become a problem. Another kid that I was mentioning got lost to follow-up, needs surgery. No. Came back 2 years later, and you can even see on his spine looks like this. Disaster. And we did it. We fixed him. We gave a lot of heartache, but it looks great. But it's very painful. Do we use neuromonitoring? So the other thing is, if we decide to do surgery, we monitor the nerves. They mean most of the neuromuscular ones. A lot of them are non-ambulatory, but they need to have sensation. They need to complain. If they don't like their wheelchair or they're uncomfortable, they will start grimacing if they don't communicate. They will communicate. They will tell you, I'm hurting or something. If we kill that sensation, it's a disaster. We still need to, as parents and caregivers, we still need to examine them. Every time we change the diaper, make sure that the buttocks are nice and they don't have a red spot or anything because of sitting too long, okay? But we do neuromonitoring anyway. In the majority of cases, we get something, or sometimes we don't get anything. I don't know why. It's just too soft or something, too much anesthesia or something. But for the most part, we get monitoring, and we need to monitor them to make sure that they have sensation. So we use little cables, basically how electricity works and what happens. Any types of instrumentation that we use, and you better believe it. But yes, any questions so far? Everybody's still awake, I think. Oh, we lost a guy there in the glasses. Yeah, he's out. Okay, he's out. Yeah, he's out. Yeah. No, you're looking inside. No, your kid is out. He's enjoying the sun. Okay, good deal. He's out, man. Yeah, good. Out cold. Yeah. Sometimes I should go into this. Yes, ma'am. Yes.
You talk about the spine continuously. Is that your specialty?
The next thing is going to be hips. Aha, yeah, baby, yeah, hips. Yeah. So no, I do a lot of spine surgery. I do a lot of hip surgery and trauma because I have to take call, and then kids just decide to. All these guys are crazy. They want to break their arms and stuff like that. So yeah.
What about feet?
Feet, not my thing anymore. I have partners that do feet, and they're wonderful surgeons, and they can do feet like you have no idea. But I decided to focus and try. The way I see it, you're trying to be an expert on something, you need to be an expert on something and not the master of all, because then I'll know a little bit about everything, but not enough to stand and talk to people and try to help them out and all that stuff. And my partner is the guy that does feet, does a lot of spine and then does a lot of feet. And he's brilliant. He sends me all the hips, and I send him all the feet. And we go like that, yeah. Okay? Yes, sir.
Spine affects the feet.
Sorry, say that again?
The spine, curved spine, affect the way the feet are turned.
The answer is no, unless you have myelomeningocele, spina bifida, but the curve does not affect it. No, what affects the feet in this population is the spasticity, the muscle tightness, the nerves are tight, the muscles are tight, and that's what gets the feet going. Not because of the spinal cord. Exactly. And that's why the muscles are tight in the arms. Everything is tight. Yeah. Okay. Yeah. But that's a great question. Yes. But in spinal bifida, actually, it can be related to the spine, but that's a different scenario. Yeah.
I have a question for you, Dr. Herrera.
Go ahead.
In the cases of scizencephaly, and if there is missing areas of the brain, and if there is muscle loss on one side and then tightness on the other, what would that specific kind of scoliosis be, in your opinion?
Usually when we have that, it's just what we call the typical neuromuscular. It's tight on one side. Some people have tried Botox. I've never done Botox, but almost makes sense. But Botox is temporary anyway. It's like when we do Botox for their arms and legs and stuff, it kind of works a little bit, but then in 3 months later, you're back again. That's why I tell my partners when they put Botox on my patient, just give me a little bit for here and here, but every 3 months I need a new renewal. So yeah. But that's the thing. Yeah, one side is flaccid, the other one gets tight, and that's what happens. And they keep pulling.
That comes from the brain, basically.
The brain's telling tight. Exactly. Yeah, pretty much. Yeah.
Okay, thank you.
Some people have tried baclofen pumps. Some people have tried rhizotomies and stuff like that. Don't let anybody do a rhizotomy. If you have it, we don't do that anymore. Yeah. It does happen, yeah. And some people still recommend it, and that's fine. But we haven't, and I think we've been happy. The baclofen fins actually are not that bad. It's just when we do have to do the spine later, it becomes a problem because the baclofen pump is in the way. So we have to kind of avoid, pull it out, pull it in. It's awesome.
Can I ask you also, what age does it stop becoming a problem? Because in this particular disorder, we see kids all the way to 25 or young adults that are getting surgery then.
Say that again. What was the first part of the question?
In neuromuscular kind of scoliosis, can it be, because some spines are fine after a certain age if they haven't gotten worse, they're kind of done growing.
Yeah.
But in this case, we see cases like where they're 25 getting scoliosis surgery. Is that possible?
That's possible, yeah.
Okay.
Again, it all depends on the numbers and everything like that. I have some people at 40 degrees and never progress, and some people are 30 degrees and they go 40, 50, 60, and yeah. Yeah. Yes, ma'am.
So having a baclofen pump, does that keep you from getting this, does it make the spinal surgery, like a scoliosis surgery, harder?
No. It's just entertaining. It's just a little bit. It's a little cable on the way, but we know how to avoid it. No. Don't know. If they recommend actually, I like baclofen pumps in that regard because.
We've had one for about a year and a half now, and it's been a godsend.
Oh no. I'm not saying again baclofen. This just makes it entertaining for me because there's a little cable, a little hose in the way. But no. It's actually really good for them. They relax them and it works very hard. So especially some of these guys are super tight.
Yes.
Super tight, and it's just yeah. And this is the only way to kind of calm them down. They don't even sleep. Yeah. Well, you know that better than me, but yeah. Okay. All right. So for the hips, the goal is to have a normal hip as much as possible at maturity to avoid osteoarthritis. All right. So the hip arthritis that we know that get total joints and stuff. So any hip subluxation, any progression of subluxation should be corrected to avoid that because eventually it will lead to arthritis. And any residual dysplasia may lead to that. And this actually applies even on schizencephaly patients and patients with cerebral palsy and what have not as well. Everybody starts thinking when they talk about dysplasia, it's only the socket, the part of the socket, but no, the femur as well can be dysplastic, can be misshapen, can be the angles can be altered. I just saw one today, and basically the hips are trying to slide out. It's mostly because of the femur, not even because of the acetabulum. So both parts of the body, because of the spasticity, the pulls, and differential muscle pull can cause that. Since we all have other type of children, just a little quick thing. The developmental ones, when they are breached and what have you, we check them because otherwise they're normal and they develop with a little bit later. And this happens also in the neuromuscular patients and schizencephaly patients and what have not. They are born with normal hips. They're in. They look pretty. But once they start developing and they start growing and the tightness and one muscle pulling, the other one is not, that's when the hip starts becoming a problem. So they need to be followed and need to be checked. And there's everything goes from minor laxity to complete dislocations. Yeah. So in newborns, it's called developmental because usually the hips are in, and then the neuromuscular ones are also they're spastic because they're normal, but then they start pulling the way out, and we'll show a case or two. It does not cause pain. And patients with schizencephaly, cerebral palsy, myelomeningocele, you name it, the hips may pop out and they may be completely dislocated, and they don't hurt. Not all of them hurt. Once in a million they will hurt. But this young girl is 14, and look at her, both hips are completely, the ball is here, the socket is down here. The ball is here, the socket, but she can squat, she can lean, she can kneel, pray, all that stuff, and it doesn't bother her. This lady as well, I mean, at some point it starts hurting, but it's just because of probably her back more than anything. But her hips are completely out, and she lives like that, and she walks and everything. So the concept of having the hips inside the socket to walk is completely erroneous. It's good, you can stand better and what have not, but you can walk with your hips out. I don't recommend that, but it is possible, okay? Sometimes the physical therapists get caught up in that. Oh, the hips dislocated, you won't be able to stand her. No, you can stand them, you can walk them, you can try to do whatever you need to do, put a standard to get the bones going, all that stuff can be done. And sometimes, like I said before, congenital things. There's not even a hip here. There's not even a bone here. Look at that. The femur bone is the longest bone in the body. This is the femur only. So some kids are born with congenital issues that also cause hip problems. Patients with sacroiliogenesis. Basically, he doesn't have a sacrum, so his pelvis is very tiny. His knees are basically fused, and they're functional. Look at that. He's jumping. He's raising himself. They do crazy stuff. So, again, sometimes it sounds crazy, but they are limitless sometimes. Bladder extrophy, we fix some of their bones. This is a kind of patient that we're looking at. You have seen this at your home or in your family, friends, or what have not. The hips are totally dislocated. And sometimes, again, as I said, sometimes this doesn't hurt at all because the ball is in soft tissues, caught up in muscle, so it's almost like it's cushioned. When it starts hurting is if the hip does not completely dislocate, it starts hinging on teeter-tottering on an edge, it becomes eroded and starts bone on bone, and that's when it causes problems. And for that, we have some surgeries. How to do it, what to do, what not to do. There's tables for the doctors to look at. So I'm not going to bore you with that. The biggest one is, and this is one of my favorite surgeries, is when they're subluxated or dislocated and they are painful. The ball is not round, it's deformed, and it has issues, and it's really painful. We remove that ball out of the socket, and we cut the bone so the patients can open their legs, sit down, and properly, and what have not, because most of these are non-ambulators anyway. One important caution is, especially if any of you are into the having babies still mode and having more children, and depending on your age, we like swaddling, but there's normal ways to swaddle. And proper swaddling is when we tie the baby's hips, bound them together. If we bind them together, the hips tend to subluxate and dislocate. So we have brochures in our office on how to proper swaddle the patients. If you're interested, hipdysplasia.org has videos on how to swaddle babies and what have not. The physical exam, again, we examine patients, and some of them are tighter, and we'll go through some of them. Hip clicks are meaningless. A click is nothing. A click is a little tendon rubbing on a piece of bone. It does not hurt. We don't get too caught up with that. Not all the hips that are dislocated will have symptoms. So sometimes we look at the look shorter or whatever, but a clunking or instability, like real instability, you can feel sometimes the hip going in and out. That's when you are concerned. We look at the gluteal, the butt creases. If they're different, that's a sign that there's something maybe happening. And this kid, one leg is longer than the other one. They're the same length, but this hip is dislocated. And that's why the gluteal fold is higher than the other one. So this is the hip that is dislocated, so the hip is here rather than the area here. Some people and the pediatricians are concerned about the thigh folds. Those are not important. Those are little chunky things, and that's it. Yeah, that doesn't bother. The important thing, see, the gluteal folds are symmetrical. That should be okay. The other thing that we have, and we see a lot of spastic kids, is with the abduction. So when you open the hip, opening the hip, spreading the hip wide as possible, and that's why we send them for physical therapy, stretching, and we insist on that when you go to the doctor or to the orthopedic surgeon, is because that makes the muscles relax and the ball will go into the socket and stay in the socket. When they start getting tight and spastic, it starts popping the hip out and starts migrating and starts moving slowly. There's nomenclature, we're not going to go through that. We do ultrasounds when they're babies, but this kind of patient, usually they don't need an ultrasound. Their hips are usually normal, like I said, and eventually with x-rays, that's when it becomes a problem. We do ultrasounds because at the beginning of life, there's no bone here. You can see the bone here forming at 6 months, 1 year of age, but when they're 1, 2, 3, 4 months, 5 months, there's no cartilage, so it would not be seen on an x-ray. And that's when we see the cartilage, see the ball inside the socket. So the socket is here and you can see it. We have some harness, some braces that we use. The babies like it usually, the parents don't. And sometimes when it doesn't work, oops, sorry about that. When it doesn't work, then we see this one is in. When it doesn't work, then we go to a type of abduction brace. And some of your patients or your kids will have these. They have this brace or they have the rhino, something that, again, opening up the hips, stretching the tissues out, keeping those hips in the socket. And they're pretty good. Sometimes the pediatricians say put 2 diapers. That doesn't do anything. So don't waste your money on diapers and save the planet. Yeah. Again, tighter when they open the hip. And actually, I saw one of these today. It looks like the hip is out or what happened. Actually, what happens is sometimes one of the muscles in the abductors or the butt muscles is tight. It makes it look like it has a longer leg, but what it has is actually perfect, beautiful ball in the socket hips. And that can happen to your guys. So for that, what we do is some bracing, some stretching exercises, and that kills it. And so again, it's always physical therapy if you haven't noticed. Sometimes we find all these, see, they're normal at the beginning, but now the ball is nowhere near the socket, so we have to take care of that. We have some lines, we have some measurements, we have some things that we look at. For you, probably important are what we call the Shenton line. So this line here, you see this little arch matches this arch here. Not so much on this side. See that? It doesn't match. This is the dislocated hip. We measure angles. We measure this angle here. Again, too steep, bad. More horizontal, good. Again, there's a deep socket, is all good. And then the other thing that we measure at some point is this angle here between the long bone and the neck of the hip, because neuromuscular patients tend to go into more what we call valgus. It's almost straight. So think about it. If it becomes straight, the hip will start tending to come out of the socket. Again, stretching helps a lot. If you have had one of your child to have a hip surgery and you have heard about the DEGA is what we use as a staple in hip surgery for the acetabular portion. It basically is a cut, an incomplete cut. This is more, don't mind the perimeter, I should have erased that one, I'm sorry. But basically what it does is we cut the bone and we hinge on the bone to push a piece of bone and we put it right here. So we cut the bone here. We take about 1 centimeter of it and we use it. Actually, I recycle it, I call it. I recycle it and put it at the top here to level this, and now it's more horizontal, so they do it on the other side. 5 years of age, and now she's 11, so I know her for all her life. And this still is not a normal hip, but she's walking, she's running, she's doing her life. But again, the ball is in the socket, horizontal. Down syndrome patients, which are also neuromuscular, have some peculiarities. The bone in the back is deficient for some reason. So when they start, the hip keeps popping back out. That happens a lot to neuromuscular patients, scizencephaly patients, cerebral palsy patients, myelomeningocele. So we need to be very mindful about this, what we do. We fixed him before, but now he's 13 and he still needs more surgery. The hip is, see, half of the ball is out of the socket. This is not horizontal. At this age, what I decided to do, and sometimes we have done this on, again, on neuromuscular patients, is a special osteotomy where we cut the bone. We do CTs, we analyze it. So you see, the left hip has better coverage, not perfect, but there's no coverage here. You can see the whole ball from the front. And from the back, you see at least half of it or more sticking out too. So basically, we had to cut the bones around the pelvis to create a special roof because the hip was popping front, popping back. It was a mess. So we have some special cuts. Oops, and they are in white for some reason. I'm sorry about that. I thought it was going to be black. But anyway, we do some special cuts, and then we take that piece of bone and play with it and put it where we want it. And now you can see that this was deficient. Now it's covered. The ball is it's a little bit deeper. So and he's happy. He's walking, and he has no pain, and the ball doesn't dislocate anymore. So in summary, we do ultrasounds for less younger kids. Abduction orthoses are very important, especially, again, for schizencephaly patients because it keeps the hips in, stretches the tissues out. Splinting, bracing, close reduction sometimes. Again, for this patient population, when it happens, they're a little bit older, so usually it implies that we have to do the bone cutting, pushing the hip back in, pushing the socket back, and then they go in a cast for 2 months or so, let the bones heal, and then we start rehab again to keep the hip in the socket. And that's pretty much it. Questions about the hip? Either you guys got it, or you're completely like, what did he was saying? You know? Usually it's number 2, that's a problem. Yes? The hip? The answer is yes and no. There's the younger, how do I say this? We have to follow the hip, and there's some criteria, what we call the Reimer criteria. So basically what you do is, let me go back. I thought I had one here, but I guess I didn't. I may have taken it out. But basically what you do is, you look at, let's do this one, yeah. You look at the x-ray, you measure little line here, draw a line, and then draw a line down the edge, and 33% or less is okay. More than 50, 33 to 50 is already at risk, and anything more than 50% of migration, meaning that the ball is trying to slide out, that means eventually it's going to do it. So might as well get into it. When they're young, less than 8, I will say, or so, 5 to 8, what we do sometimes is cut the tendons in the inner groin. Again, remember I talked about spreading the legs. We cut the tendon and we put them in cast, again, to spread them, give them physical therapy, and that, again, by doing that, allows the ball to push on the socket. So it looks more like, let me see if I have one here. I guess not. Sorry about that. I thought I had one too. See, she's at rest here, but think about it that way. If she is spreading her legs, like when we do after that surgery, the ball is pushing. The ball is pushing on the socket to allow it to form better. After 8, usually that's not going to be enough. Some people do one hip, some people do both hips. I think one at a time. If the other one is forming okay, we keep an eye on it. Again, it's all more about philosophy than anything else. But yeah, there's some ages, 5 to 8 for the soft tissue. After that, usually ends up being bone. Because the body, you cannot predict the body will behave after 8. The body is maturing already, so it has some time has happened. Yes.
In doing that, if only doing one hip, what is the chances of the other one becoming subluxed?
I cannot give you a number at the top of my head, but that's why when we do the X-rays, I always do an X-ray of both hips, the pelvis. We do a pelvis X-ray, at least one, to see what's happening on the other side, and sometimes, and that's very important because sometimes you need to you get focused on the let's say it's the right hip that is the one migrating, and then you lose perspective on the other one. The other one is sneaking up on you. But usually it's either they're very symmetrical. They kind of tell you what the one side is doing, the other one will do as well. But once in a while, it's only one hip. I don't know why. Sometimes because of contractures, because they had that abduction contracture. So if you had that abduction contracture, the hip is pushing in, so then they're windswept. Their spine actually sometimes causes the hip stuff. That's a question that you had. Not because the nerves are throwing messages to the hip. It's just because if the spine is crooked, the pelvis gets crooked, and then the kid ends up being in this position. So this hip is safe because the ball is pushing the socket, right? But this one is like swaddling. Like I just told you, don't swaddle the legs because it tends to pop it out. Okay? So that's why usually one is more than enough. Any other questions? Anybody? How many have had hip surgery or spine surgery of your children? Oh, I know you have. Yeah. You're welcome. Yeah. Sorry, I guess I don't know. Whatever. Either way, she still talks to me, so I don't know what happened there. Yeah. And for what? For the hip or the spine? No, I know you. No, I know you. I mean, I know what happened.
My hips.
Your hips?
Yes.
How old were you? Do you remember?
Well, my first one when I was 5 because legs were turning in.
And what did they do for that? You remember?
Take some screws in. That's.
Okay.
And then a year later, I got them taken out because
Yes.
they're still growing.
Yes.
And then in 7th grade, I started having hip pain. Like I would help my mom in the kitchen a lot. But then I would have to sit down and it would make me like a big supper or something. And so finally my mom made a doctor appointment with my doctor. And he had x-rays and the ball of my hip, like the ball was doing like this.
Slipping out of the socket?
Yeah, so that was in 7th grade. And a year and a half ago, I just had my first surgery on that. And with the 2 surgeries, he put 14 screws and 2 plates to fix it.
Where do you live?
North Dakota.
North Dakota?
And
Okay.
I go to St. Paul for my doctor.
Oh, who's your surgeon?
Dr. Healy.
Okay, cool. Yes. Good. Awesome. Good. Well, thank you. Yes.
What's the chance of how the child is when they get older if you don't do anything with it?
Say that again?
If you don't have the hip surgeries and they have the subluxation on the hips and everything, what if you don't do anything? How is the child going to be?
And that's a basket of surprises because I'm not sure. It's like depending how the level of involvement. If it's heavily involved, it may not be a problem. The hips may dislocate, and as long as you can, and that's one of the things I tell my parents on non-ambulators and kids like that, is that it may not be painful, but it becomes a problem to clean the diaper or sit them around or do things like that, things that we don't usually think about because we can. When that becomes a problem, that needs surgery, but if it doesn't, and sometimes the hips can dislocate, and like I said, if they don't hurt. And if they don't hurt, I don't touch them. I love doing surgery like you have no idea, but if they don't hurt and they have no issues with sitting them in a wheelchair, taking care of them, we let them be. If they're ambulators, they're very functional, they're active, they do stuff like her, then you try to get involved and go right away after it, because if you don't, then it's too late, and then it starts hurting, they develop arthritis, they have an issue, and then there's some stuff that we cannot take care of, even as good as we can be or try to be. There's some things that I cannot repair, and one of them is dead cartilage or damaged cartilage. We cannot repair that. So we try to avoid it, and sometimes they don't hurt. And that's a very hard thing for me to do. Sometimes I'm selling surgery to people on their hips that do not hurt. But you see the changes, you see the bones starting to slide out, and say we have to do something before it becomes painful. Because then I cannot do anything. I can put it back in, but maybe the damage is already done. It's a very hard sell. Most people buy into it and say, you know what, that makes sense. Think about it, and the way I try to explain it is like the tires of a car. If they're on balance, it starts peeling on one side. The car still runs. The car still runs, and what happens one day? Goes away, or flat tire, or whatever, is already peeled off. And that's what can happen to the hip too. Okay? Look at the socket. This part here, let me see if I have a better one. This one here, think about the ball and the socket as a hat. If you have your hat all the way straight, it holds all you don't get wet, right? You don't get the rain. The other way I like to tell people is, if your hat is like this, or think about pressure, right? So if you have flip-flops or tennis shoes and you stand on my head, it bothers me. But if you have high heels, meaning only one part of the hip is taking all the load for walking, it's going to hurt like crazy. So the idea when we do these osteotomies, these bone cuts, is to have the flip-flop again back on top of the head, which as uncomfortable as that sounds, but right? But that makes sense. Okay. Any other questions?
Yeah, so the length of the legs, you see, so the length of the legs, is that a factor, like, for the hip dislocation right now? She don't walk or anything with her. She got her right side is longer than the left side.
Wait, is one side dislocated?
No, right now it's just a small click, but they don't hear it anymore. But right now you can tell, maybe for the tightness and everything, but her right side is longer than the left side. Would that be a factor later on that we have to worry about? Or or?
You need to make sure, okay, so the leg can be longer for various reasons. One, that it's just longer, and it all depends on how much longer. There's people in the planet, about a third people in the planet have 1 centimeter to 2 centimeters longer leg than the other one, just like a hand, just like our ears, whatever is different. And that doesn't become a problem. But the leg can be longer, and what we do is monitor that and make sure that if it's, let's say, 0.5 centimeter to 1 centimeter, in 2 years it's the same distance, same distance, same distance. If it starts doing this, one leg is way longer than one shorter, that's bad. Two, it may be because one leg has contractures, and even, okay, so my legs are the same length, I think. I may be the 2/3, I don't know. I never measured them, but if I have a contracture of the knee, now my leg is floating and looks shorter.
2 inches.
Centimeters. 2 inches what?
2 inches, that's the difference in mine.
5. That's 5 centimeters. Oh, you?
Well, I try.
Yeah, 5 centimeters. Okay, so it may be because the muscles are tight, either in the hip or the knee or both. So now the leg looks shorter, even though it's not. I saw a kid today with the same thing. The daughter of a doctor. It's like, I don't think she's short. It says maybe because she has a contracture. And that was the case. She had a contracture, but when you lay them down and you do the knee thing and all that stuff, this is the same length. So it all depends again. Or it may be the hip that is subluxating and coming out. Again, depending on the age and what happens.
And then you wouldn't recommend no surgery or anything for like at least they're 5 years old?
No, I did not say that. Whoa. No, I did not say that.
I'm asking like...
No, if the cause is something that needs, like, for example, the hip that is dislocating, don't wait.
Yeah, all right.
I mean, if it's dislocating, then yeah. I mean, but if it's just normal, then it's just like she has a
October, so I want to be sure and ready.
Say that again?
My follow-up with her is in October now, so our hip and all that. So I want to make sure that once...
Where do you guys live?
Boston, Springfield, Massachusetts.
Okay. Where you go, Children's?
Yep, Shriners Hospital in Springfield, yep, and Boston Hospital.
Okay, cool.
So I just want to make sure, once we're there, we hear a lot of different things.
Again, it all depends. So you need to ask him, why do you think the leg is longer or shorter? And then based on that, then you can make decisions. Yeah. And sorry, I don't do upper extremity. I don't do hands or elbows or anything. You don't want me to do that. I will. So I'm not going to talk about something that I can't. It's not my thing. Any other questions? The kids did very well, huh? Right? They did behave very well. All right. Well, thank you.
I have a question,
Go ahead.
what do you think that they should ask their doctors? Like, what should they be looking for?
Wow, that's good. Oh, whoops. Yeah. So what should they ask their doctors?
What should they be looking for? Because the hips can be deceiving.
The hips can be deceiving. So always ask the same questions you were asking me. So what if I don't do anything? What do you think is going to happen? And that's why I do surgery. So if you know more or less what's going to happen, we call it that natural history. If you know at the end something bad is going to happen, then you do surgery. If you're like, it's a little bit wishy-washy, I'm not sure, then you wait. You follow me? If it's something that, so always ask them, so what do you think will happen if we don't do anything? Does it hurt to wait 6 months or a year? Or do we need to do it sooner rather than later, and why? And if they know what they're saying and they know what they're doing, they will tell you right away that this is because of this, because we have seen it progress and move the hip. The hip has been slowly doing this. And I don't know, I always offer my patients second opinions. If you want to see somebody else and see what they say. I don't mind. For the most part, I mean, these are your beautiful children, so I would. Unless I know the person who's taking care of me is the bomb and they do okay, but then fine, then do it. But if not, it's like, let me talk to somebody else. And you will be surprised at the difference of opinions, or they say, no, they all say to come back to you or to go back, and that's fine.
What if there's several issues? The hips are subluxed, feet are curving in. how do you determine which doctor you see? Because you said you only deal with basically the hip.
Well, hopefully you're going to a place that they have more than one first. I like that because the variety. There's 4 of us, hopefully 5 soon. And every week, on Fridays, today we have one, we do a conference of all the surgeries that we're going to do the next week. And sometimes we bring a case that we're not sure, say, what do you think about this? Will you take care of that? Can you take care of this because I don't feel comfortable? And they come to me and they ask me about hips and I take all of them. Sometimes I go to them and I show them, hey, I have this patient, can you take care of their feet and all that stuff? It's hard, I know. It's hard because it's like, how do you feel comfortable without insulting the doctor? How many surgeries have you done? Don't ask them that. It kind of hurts. How many have you done? Say, I don't know. Are you qualified? Well, I had a diploma. I don't know. Maybe. I don't know. They think I am. They gave me a job here. So, but you never know. Some people have diplomas and they should not be doing anything. So that's the other thing. Yeah. To be fair about it.
Oh, we know that.
Ask your pediatrician. Ask about their reputation and things like that. Googling is dangerous.
That's great stuff.
Googling is dangerous. Not everything in the internet is true. About the procedures, about somebody's reputation and stuff like that. But then again, if everybody else it says he's bad, then maybe it's true. It says one person he's awful and everybody else says he's baby Jesus, then probably he's okay. But I cannot please 100% of people. It's impossible. Nobody can please 100% of people. And that's fine. So yeah, so experience, how many years do you guys do? Do you, on very difficult spines, I always get a partner. And so did Harry, probably. He did it with John and everybody else. Yeah, yes, he did. Because it's you two brains, 2 people that are experienced going at the same time. That's a good solution. Do you do it with somebody else? No, just with my PA. Find somebody else. If it's a straightforward 50-degree curve, please. Yeah, I do it by myself. I do a resident or something, then we do it together. But it's a 100-degree curve. Like big cases like this, I always get somebody else involved. We go quicker. Everybody takes a break for a second, drink some water. While the other one is working, 2 brains at the same time working together is better. So that's another way to think about it.
Out of curiosity, I just looked at my daughter's X-ray that was done in May.
Oh boy.
And they were normal, but it says coxa valga. Can you explain that? Does that have anything to do with schizencephaly?
So coxa valga is what I told you. See, remember I said that it's either the ball or the socket or the ball? Basically what they're saying is that this angle here is a little bit increased, so it's at risk. And that happens a lot with neuromuscular patients. The muscle pull is different, so what we do for that sometimes is we cut this bone and offer it, or just keep an eye on it. But if it starts sliding, there's a little bit of a risk. Yeah.
I've got a question. And you had said it's great to get second opinions. I think that's great. Unless you're the doctor, then we don't need a second opinion. But when the family does have to go get a second opinion, how does that, and this may not be the right question to ask you, but how does that work with their insurance? Does the insurance companies have an issue, hey, we gave you this doctor is qualified, well, I want to get a second opinion?
No, usually you talk to the pediatrician or you Google and you find the competition and you go ask them, or you find an expert in the nearby area or something that you Google and you go in that area. Referrals. And so, or sometimes if they say, would you recommend me anybody? That's another way to go about it. And the insurance says, well, you're going to get billed like anybody else because, again, it's a visit and the other person has to do their work. But usually it's either the pediatrician, friends, people that you know and stuff like that. Oh, I heard about this guy, I heard about that guy, and then you go. Sometimes even the same partners in the same group.
Right. No, but as far as that goes, I understand that you can get billed, but does the insurance companies have an issue with having more than one doctor seen?
Say that again, with the what?
So I understand that the insurance, or the doctor, both doctors would have to pay, battery guy. I know that both doctors would obviously get paid, but does the insurance company have any issue with paying both doctors? Okay.
If they, depending on the insurance, if you need a referral, the pediatrician will give you a referral and you're done. If you don't need a referral, you go see somebody else. The other day I was the third opinion. Kind of hurt my feelings. But guess who's doing the surgery? But at the same time, I go, why you have to go to two people? Yeah, so anyway, yeah, but it's all working out, yeah. No sour grapes. Anything else? Well, thank you for your attention. Thank you for not falling asleep. And good luck. Enjoy the meeting.